Dr. Sheila. It's an honor. Dr. Stalwart seniors, Dr. Arvind, Dr. Niti, thank you, Dr. Aditya, Dr. Purvasha. We need, of course, a lot of collaboration on that. I'll be speaking on AI. AI in terms of the work I've been doing at an end in corneal refractive surgery. I think my journey was more accidental into AI, but now somehow, due to my PhD, it's an aspect of work which I'm continuing. I think the wonderful work at LBPI in terms of segmenting images. So there are two aspects. One is you are putting images, building a database, and then utilizing the images to predict whether there's rejection, whether there's infection, whether there's scar. Many aspects of scans which we do in refractive surgery, there is raw data. So these are the two aspects of data points which are generally put into an AI algorithm, and that is the concept of machine learning, where we are actually putting in data, trying to teach the AI in terms of looking at whatever we need to look at. So if we're looking at keratoconus, whether it's detecting keratoconus correctly or not. So accuracy of data in terms of what you're actually putting into AI is very important. One aspect is, of course, quantitatively the number of patients. Normally the understanding is more the data sets or more the data points you put in, the more accurate the AI is. And what we need brought in very importantly is also the quality of data, right? So edge detection, you need to be giving the right data to the AI. That's also equally, in fact, even more important than just plain numbers. I might have 1,000 scans, put in 1,000 scans, and this is something we learned in retrospect when we started working on KC and Pentacam, where we found that there was something known as an edge detection issue. And AI area under curve is sometimes very, very skewed in certain scenarios, and we had to go back to individual scans and try to correct the quality of scans. Okay, so that's something important in terms of even in keratoplasties, even in data when you're trying to look at scans, Pentacam scans, anything. If you're looking at AIOC2023, it's important to look at quality of scans. So there are various classifiers. For want of time, I'm going to skip to it. You are putting in data. So how is AI trying to classify that data? So there are various classifiers, something known as random forest, something known as SVM, something known as neural networks. To simplify it, if you're looking at an RF classifier, it basically has multiple decision trees. And if you see these branching patterns, each one of those nodes are actually one of the values which an AI kind of assigns. So what AI does is it takes all the data, uses multiple regressions or uses these multiple decision trees and tries to allot variables at various levels of the decision tree. So this is what a multiple decision tree classifier is, what we know as an RF classifier. So an important aspect is training, but is also testing and verifying it. You need to know whether what the AI is learning is right, and validation is an important step in AI, right? So many of the algorithms or softwares we use has an inbuilt subset. For example, if I put in 1,000 patients, it kind of takes out 200 of those patients and tests and validates. So it uses 800 for training, it uses 200 for testing. So that is an important aspect of the models which we build. It's important that we even validate that, and that is something we've learned, and we are validating the studies we're doing. So I've looked extensively on keratoconus and in refractive surgery. This is something we started 3 years back, where we wanted to look at how AI can look at predicting keratoconus. Now, obviously, the relevance, clinically, people might ask, what is the clinical relevance in these kind of scenarios? And that is something which we are now applying to our clinics, where we are using softwares, and in due time, this is going to be integrated into existing imaging devices, and it could be an indicator to clinicians, that these are the parameters which you have missed, and these are the parameters which you need to be looking at when you're following up these patients. So what it helps us looking at is looking at parameters or indices which we generally miss, and that's where AI comes into it, is where it's combining those indices or parameters which we miss. Because you might say, I'm looking at Kmax, why do I need your AI tool? On the corollary is the fact that we need to look at certain parameters which we might not look at, and AI is helping us in comparing and combining those, and that's what is important, where we kind of accurately predicted progression and looked at these multiple parameters, and this is something we published. What is also important, Dr. Kavya spoke about epithelial mapping, is that any AIOC2023, epithelial mapping is an important tool and armamentarium as a cornea surgeon, as a refractive surgeon. In refractive surgery, the challenge is in the fact that epithelium is a masquerader, and it actually hides many things which we miss. you're looking at keratoconus, you're looking at an early KC, it's actually a stromal change. And epithelium can be something sometimes confusing, and that's where an ideal imaging tool is trying to extract that. So we have a tool which is known as an MS39, where we used 2,000 of these patients and tried to validate that concept that it is actually at the Bowman's or at the stromal level where the disease processes are. And many of these parameters which we found are not epithelial, but more of Bowman's and at stromal level. So that is something which is important, and it was accurately predicting which of these patients would are KCs or are FF KCs, etc. So that this is a paper which we also looked at and published on looking at these markers in the instrument which I spoke about, which is MS39. An important aspect of any disease process is you need to remember it is not only imaging, it is also demographics and other risk factor stratification. Keratoconus is a clinical diagnosis, not a diagnosis by pentacam. So what we found is that it's a challenge to integrate multiple modalities. So for example, looking at imaging, and then you're putting in demographics, and that is something which we kind of struggle to look at. And just one more minute. So this model is where we kind of validated our first model and also integrated many risk factors like eye rubbing, IgE, and this is something we kind of successfully looked at, one aspect of demographics, one aspect of imaging, and integrated that. And this is something which is in translation, where this is, this will come as an app where you need to put in these high-risk characteristics and it gives you a score or a risk stratification score. A little bit of work we've done on IVCMs, a wonderful talk by speakers prior to this, where patients coming with eye pain, this is a continuation of the wonderful work done by Dr. Sharon on stratification of patients with ocular surface pain. We kind of looked at systemic factors, non-strabismic binocular vision anomalies, as well as confocal changes in patients presenting with eye pain. Not all eye pains are dry eyes, so it's important to look at these individual patients. It might be just 1% of those patients who don't respond, but looking at imaging, confocal, systemic parameters, and an aspect of orthoptics is equally important. The last work, and I think this is something which we recently published, is before patients come in for any surgery, there are so many determinants which can actually affect the way we do a surgery. Maybe the waiting time outside was too long and he got angry with you. Maybe the insurance was not right and this patient did not turn up for surgery. So these are models which we did in collaboration with Zeiss. This will come into EMRs, where they will flag off certain red flags.
Gairik will request you to summarize.
So to summarize, AI is not the future, it is the present. There is a lot of work which is being done in terms of imaging, integrating imaging, and I think collaboration is the next big step where institutes can share databases and we can validate models. Thank you.